time. And this exam that we're working on this week is about safety and infection control, one of the 8 categories of client needs that the Nclex evaluates, right? Because the Nclex evaluates not by subjects, the way that we studied in school, but by client needs. And those client needs are 8. I am not going to go over them. If you are part of the integration team, the Bright Star, you probably will know this or will learn about this today. I'm going to discuss about what those 8 categories are and why we want you to study using those categories, okay? So this is the category, again, of safety and infection control. So all of the questions that we're going to have on this exam are about that, safety and infection control and infection prevention. Will anyone like to read today? Don't be shy. We don't bite, I promise. We also don't make fun of accents. We'll have one. All right, I'm going to start and then I'm going to warm up. And if someone wants to start reading later, feel a little more comfortable, you can go ahead and open up your mic. All right. So we have during shift change, the night nurse notices that the graduate nurse administer IV dopamine instead of the prescribed norepinephrine for a client with sepsis. What should the night nurse do first? So this is a question of priority. Obviously, there is a medical error there, but it's a priority. Are we going to administer the correct medication and obtain the current vital signs? Are we going to alert the graduate nurse and complete an incident report? Are we going to assess the client and notify the healthcare provider? Are we going to discontinue the dopamine and inform the nursing supervisor? You can also send me your answers in the chat if you feel a little shy and you don't want to open up your mic. Let me open up my chat on my phone. Go ahead. Assessment. Very good. So you like number 3, right? Very good, Laura. Very good, Noel Kiss. We're going to assess. Very good. This is a question. Sometimes you will see that there are some questions in which assessing might not be your number 1 priority, depending on the options that are there, but we know or add pi. Assessment before implementation. Now, if the question is already giving you assessments, they're giving you a bunch of information and telling you that the assessment already happened. As a strategy, usually your answer will not be another assessment because they're already giving you a bunch of assessment. It's usually an implementation. And if they give you assessment and implementation, usually the answer might be something regarding what's the next step on the nursing process. If you have assessment, diagnosis, you have implementation. What's next? Let's say you did your planning already, right? The ADPI, assessment, diagnosis, nursing diagnosis, also could be thinking about a medical diagnosis. Then you have your planning, what we're going to do. And then you were going to have implementation. And if all of this is done, then what is the last thing that your question is probably about? Evaluation. And along with that evaluation could be maybe education, right? The client is going home and we need to give them some nursing education regarding a medication, regarding a procedure, regarding a disease process, something that they need to do or follow up at home. Very good. Obviously, when something like this happens, the number 1 thing besides is not looking at the monitor, is to go and see how your patient is doing. Did they have any adverse reaction or any adverse effect to have given the incorrect medication in this case, right? Even though they both pretty much have the same intended purpose, this is a clear medical error, right? You gave something that you weren't supposed to give, which is why when we are brand new, ask, don't get tired of ask. Nobody's going to think less of you. Even if you have the knowledge, sometimes you have the knowledge and you know what you're doing is correct, but always confirm, always double check, because things change very quickly in medicine and in acute care, for example. And maybe a doctor wanted something and then all of a sudden the order changed, they discussed, they talked, something changed with the lab work, with the vital signs, and then the doctors make the decisions and they might change an order. So always ask, hey, doctor, or hey, another nurse, I was doing this and then, now I'm having this. What do you think? I'm thinking that I should do this. Do you agree? Or you have some different advice? Ask, because we're brand new, you don't have the knowledge. There's people that have been there 15, 20 years and still there's procedures and protocols they don't know. So don't be afraid of asking. Great job, guys. So although yes, everything else is correct, that's not our answer. Always, always first, how's the patient do it? They're telling you in a question that there's a flat line in the monitor. The first thing will not be for you to start CPR, right? You gotta go and see if the flat line is there because maybe one of the leads fell off. Is the patient not even connected to the monitor? If you go into the room, the client is talking, the client is breathing and talking. Obviously, they're not dead, right? So assessment first. Very good. The nurse on the postpartum unit is caring for assigned clients. The nurse should first check the client who reports that a suspicious visitor is walking up and down the hallway. They had a cesarean section birth 8 hours ago and is requesting to ambulate for the first time. There's a client who has endometritis and reports that the alarm on the IV infusion pump is sounding. And then there is a client who reports that the newborn is crying inconsolably and having difficulty breastfeeding. So, who do we go to check on first? Remember, this is about safety and or infection control. Also about priorities, because all of these things will happen at the same time on your shift, probably with your patient, or sometimes not even with your patient, with another patient. And we have to prioritize. That is one of the most difficult things to learn how to do because we want to do everything and we want to please every patient, especially at the beginning. But it comes a point in which you have to prioritize. There are things that require your attention right away. There are other things that can wait. Doesn't mean you're not going to do it. It just means they're probably going to happen at a later time. Go ahead.
Is it number 3?
You like endometritis, reports the IV pump is sounded. It could be. It could be depending on, there are certain medications that when the alarm is sounding, you need to go. We're going to go and discuss about that. Go ahead. Someone else was going to say something.
Or
One, you like number one. I think Noelia also likes number one. There's a suspicious visitor walking up and down the hallway. And let's keep in mind which unit this is, postpartum unit. We don't really necessarily right away go and think about what are you guys thinking? You tell me, what are you thinking with this suspicious visitor?
I think it's for
You think it's what? I'm sorry.
four.
One, you think is one. A suspicious visitor,
Number
like number four. Oh, I'm sorry, number four. Okay, I couldn't understand you. Eileen also likes number four. Eileen says, okay, so we are between one, three, and four, and I guess none of you is concerned about the ambulation of the mom, or not concerned, meaning that this can wait, right? Okay. Um, let's go back one by one and see. Right. So for number one, what would I be worried about? Probably a suspicious visitor. Someone is acting suspicious. So how do we identify suspicious? Now, obviously, unfortunately, we live in a time in which we all, not even this time, innately, we have what is called biases, right? We see someone and we're like, we initially kind of have our own bias and our own preconceptions that we're going to apply to the way someone is presenting by. Now, when someone says someone's suspicious, I would imagine someone that you can tell by their body language or their appearance that they're up to no good. And usually we can all tell, right? When you look at someone and you see them that, okay, this person's not acting right. They look like they're about to do something. They look like, I don't know. And here they're telling us she keeps walking up and down. What is this person trying to do? They are, this is the postpartum unit. Unless the baby, there's something wrong with the baby, the babies are usually going to be in the room with the mom. The mom who just had a baby who's probably in bed rest, even if she can't get up, it's not like she can jump. And probably if someone comes into that room and tries to take a baby or an abduction, is what I'm thinking, right? Harm the baby, right? I think it's less likely that someone might come in and actually just go and try to harm a baby in a room. That's possible, but they can also abduct a baby, and that's also something that happened, right? A person can come in and steal a baby. We used to hear this more a lot in the 80s. Now we don't really hear much about, not because it doesn't happen, but because there are safety measures that we take now to prevent that. Doesn't mean it doesn't happen now. For number three, endometritis. So she's got an inflammation or an infection of the endometrius. They're probably on antibiotics. Probably the infusion pump is sounding because there's an occlusion or the antibiotic finish, and it's a very annoying, you know, noise. And you will have patients that will go crazy and will start screaming because then will get aggravated because the pump is sounding. Unfortunately, that is usually not a priority unless you are in an ICU setting or and you are running something like pressors, which you know that if the person that is running pressors or sedation, right? They're intubated and they have sedation. When the sedation stops, there are some of these medications have very quick half-lives, meaning that once they stop, then the number one thing that's going to happen if it's a pressor medication, the blood pressure is going to tank within seconds. And you know that you have, and if the blood pressure tanks, then the heart rate follows and the person can go into cardiac arrest because that hemodynamic instability. So very important. Those are the alarms that you always need to go and see. So that is variable, right? Now, let's say that okay, what she's running is just antibiotics. If they finish or if there's an occlusion, most antibiotics you will have, she'll be fine if she wait 5-10 minutes before you go and check on that alarm. Um, and let's say even if it doesn't, even if it's something this will still give you a little bit of time, right? Ignoring the fact of what specific antibiotic or what specific medication they're running, an alarm sounding, someone else can respond to that too, right? Like if you have an emergency somewhere else, someone else can go, or that this can be delegated. Hey, can you go and check and see what's that alarm sounding for? And a lot of the times it's an occlusion. Usually alarms, occlusions happen because, IVs are maybe in these areas where the person bends their arm, right? There's flexion occurring. So maybe the person's eating or they're on the phone and they just bended that IV and all they need is to extend their arm and it just goes back to normal. But I also don't see this as like a number one. I think this person can still wait. For number four, I do not like the fact that it says that the infant is crying inconsolably because it could mean several things. Now, they're also telling us that the baby is having difficulty breastfeeding. So maybe they're just hungry, right? They're just babies will cry inconsolably when they're hungry. And, all we need is to feed them, right? It doesn't necessarily pinpoint to something that is terribly wrong if they're having difficulty breastfeeding, which is a normal, like a common thing that could happen, sometimes if the mom is too engorged, they cannot latch properly. Sometimes again, the mom doesn't have experience. This is painful. So that can be difficult at the beginning. And the baby could be crying inconsolably simply because they're starving. Yes, it's a priority in the sense that we need to feed the baby. It's a basic need is food. I don't know that if I'll tend to this before that client that might abduct a baby. You guys tell me. But this is my rationale. I think number four might be a little bit of a distractor because of the crying inconsolably. Inconsolably tells me, okay, something might be wrong. But they're also telling me, oh, they're having difficulty breastfeeding. So they're hungry. I don't know, based on my rationale. If you have a different rationale, please tell me, and then we'll we'll go about like that. But I think we can safely eliminate number 3 as well. And then we'll be down to 1 and 4, which is usually how it goes in the exam. You do the whole thing and then you're down to 2. Now we're a 50-50 chance. So what do you guys think? Open up your mic. Don't be shy. Tell me. Listen. No. I'm thinking crying inconsolably could be this. Because I can be wrong, and I've been wrong many times. Come on, guys. Tell me. There's no wrong answer. Melanie thinks that number 1 is an issue of safety, and safety is a priority. I like that. And especially, obviously, the key is that this part of the exam is about safety as well. Also, the fact that the Nclex is mainly an exam about safety as well. So if something represents um, a possible harm to the client, but a lot of you like number 4. Lisa likes number 4. Laura likes number 4. Eileen likes number 4. Addis thinks number 1. Okay, so here, let's see who, we're going to do this democratically, right? So I have 1, 2, 3 for number 4, and I have 2 for number 1. Oliden, I don't know, or anyone else, Nicole, Marie, Gerald, hi. Junie, hi. Noelio. Anyway, it doesn't matter. Let's figure it out. Let's go with 4. Okay, I have another one for 4. We're gonna go with 4, and then we find out. Okay, so it is about safety, guys. Yes. Yes. And let's see why. I know the word inconsolably is what threw you off, right? But babies will clap
100%.
100%. And that's why I said I would also be concerned about the word inconsolably, because that means that everything, no matter what you're doing, the baby keeps crying. But again, they're also telling you the key right there: difficulty breastfeeding, the baby's starving. So let's give him some formula. If the baby stops crying, problem solved, right? But again, safety. If this suspicious visitor, you're not paying attention, you ignore the mom, you're going to give a bottle to this baby who's crying, and while you go into that room, this suspicious person comes in and just grabs that baby from the bassinet, because usually in those rooms, the babies are in the bassinet, and then just take off with the baby. That is a problem. So what they're saying here is, yes, they are a vulnerable population, and yes, infant abduction happen. Um, like I said, in the 80s, this would happen. And all those crazy movies that we see on timeline, that would happen. People would go, and women, and women or men. Obviously, there's a group of women, especially women who had like previous miscarriages or difficulty getting pregnant, or sometimes just simply mentally unstable patients will go and abduct or try to abduct an infant. Now, like I say, we don't hear about this as much, because usually most hospitals have different things that tell you, um, or different protocols for the maternity ward. For example, they might have different badge, a different color badge. So if you see someone that seems like a nurse, but the badge is different than everybody else's badge, maybe that quote unquote nurse is not even a real nurse, or maybe it's a person who shouldn't be there. Number 1, they have different security systems. There are bracelets sometimes that act as a GPS, right? And or an alarm that if that little bracelet leaves that unit, meaning someone attempts to take that baby out of that unit, it will alarm. It will make the alarm sound to let everybody knows, hey doctor, how are you? Todo bien? Good to see you. To let everybody know, okay, this baby is leaving, it's not supposed to be leaving, right? Which is part of, I guess, those nurses that work there to ensure that, yes, the right baby is living with the right parent, and to inactivate that alarm so the parents can leave and that alarm doesn't sound. Different hospitals, like I said, have different things. It could be an alarm, it could be like a little GPS so they can actually track what the baby is. Um, you know, uh, what other things they do? Yeah, like the color of the bracelets, the color of the gowns are different. So if you see those patients or those babies in a different unit, some units even have different color uniforms for the nurses. That way, if you know that that nurse specifically works on that unit, and no other person should come to your room with like a different color and say, "Hi, I'm the nurse. I'm gonna take your baby because we have these stats to do." And then that nurse has a completely different unit, and it turns out it might not be a unit, a nurse at all. And like we say, we don't really think about this much, but yes, babies and maternity wards are what we call a vulnerable population or a vulnerable group that requires special attention when it comes to safety. Okay. So I guess right here is what they say. They can have matching mother newborn identification bracelets. Yes. And usually when they are brand new, you might notice that the bracelet on the baby doesn't really have the baby's name, but it will have the mom's last name. So it will say something, okay, baby Valdes, baby Babani, right? Something like that. And it will say boy or girl, right? So baby boy Babani, and then it will have their bracelets matches mom's bracelet. Security sensors we talk about, locked perinatal units. Yes, usually, like I said, they have a separate security system. So you can walk into the hospital, and to most unit, you can just walk in, right? And the rooms are right there. Um, Obviously, surgery also have like separate doors that someone needs to let you in. ICUs have this as well. Perinatal units will have this as well. And sometimes some hospitals have a whole different like security desk. Like you pass through the regular hospital security, and then you have to pass through a different security desk that is specific for the maternity ward. We talk about the specific uniforms for nursing and staff, unit specific badges. We talk about this. Overhead emergency alerts. Yes, this is very important. If you work at a hospital, they will probably going to have a code pink or a code something, a different color, a different name, if there is a suspected child abduction. Like in our hospital, we have drills for this, right? And everybody will receive an alarm on the phone, and it will tell you, you know, there is so and so person and they abducted a child, right? Because again, it's a vulnerable population. Very good, guys. Now let's see why not number 4. Number 4, when feeding difficulties occur, hungry newborns can become frustrated and begin crying. And yes, that crying will be inconsolable. Although distressing to parents, the nurse can assess to the client and newborn after addressing a possible security concern. Absolutely. Like I said, this baby is probably just very, very hungry. Good job, guys. So do not ignore this word, right? If this word comes in and they're all there, because they will give you clues. The Nclex is very good. But it's very good at asking, but it also, they know that they're evaluating brand new nurses. So they will give you clues in the questions. They will give you the word inconsolably, but then maybe they give you other manifestations that need to make you like the little red flag pops up. But if they give you inconsolably and then they give you like a logical explanation that it doesn't necessarily mean an immediate threat to their safety, inconsolably can also wait. Obviously, safety of the baby, if there's a question about a parent, right? The baby's crying uncontrollably, and then it's the parent that says, I cannot take this anymore. I've had it. In that case, there is safety for the baby, but because of the parent, a parent that's telling you they're so frustrated that they can lose it, the parent needs to be separated from that baby, right? Until they calm down, until they relax, until, baby is probably, even if the baby keeps crying unconsolably, it's probably safer for the baby to be crying in their crib or in their bassinet away from that parent until that parent calms themselves down. Very good. The nurse should consider which of the following client reports as an indication of an allergic reaction. I can eat broccoli or cabbage when I take my warfarin. I get a headache when using my nitroglycerin patch. My feet swell when I take philodipine. My lips swell when I eat bananas or avocados. I was thinking about this today, about how many people have in their medical record an allergy listed that isn't really an allergy. Sometimes when you ask a person, oh, what you're allergic to this, what symptoms do you get? And then they tell you like unexpected side effect of the medication, and you're like, you just think like, wait, that could happen. That's an adverse effect. Or they will tell you, well, that is, or you will think that is the expected effect of that medication. It's not really an allergy. Um, Okay, very good. Here I got everybody number 4, right? Absolute lip swelling. That's an indication that if you eat this, your lips are swelling. That is a hypersensitivity reaction. Remember, this person could also have a cross allergy with latex, right? So make a list if you, I don't know if you like to take notes. I love to take notes. And I'm going to teach you how to do, let me see if from here we can do a flashcard. Yes, right here, flashcard. There you go. So this is very good. You just select whatever you want to do. You can put it here, you can put it in the front, or you can put it in the back. You can switch it, and then you can put a tag here, right? It says drugs advance report, so you can then find it later. All you do is click save, and then you can find all your flashcards later to study. Like I said, you is a very, very good tool. Obviously, eating broccoli or cabbage when you take a warfarin, the reason why they cannot is not that they cannot eat it. This is the whole vitamin K being the antagonist of warfarin. Cabbages and broccolis are high in vitamin K, and we know that what we should do there is not it's not to stop eating it. What we need is to maintain a balance so it doesn't throw off the warfarin. So do not go too high. Do not eat a lot because then you're blocking the effects of warfarin. But do not stop eating it because then the warfarin can become, I guess, the effect could be maximized, right? Not an allergy. Headaches when using nitro patch, we know that's an adverse effect. This is a vasodilator. Headaches could happen with nitro patches. It's an expected finding. Feet swell when they take philodipine. This can also cause, this CCBs, the calcium channel blockers, can also cause a little bit of swelling in the feet. It's, again, vasodilation. It can cause that fluid accumulation, another expected finding. So very, very good, guys. This was pretty clear, right? And the NCLEX will have questions like that, or straightforward. What I want you to take from this is, remember, people that have latex allergy can have a cross allergy to other foods. For example, bananas, kiwis, avocados, tomatoes, peaches, and grapes, okay? Because they have similar proteins. The rubber that is in latex have similar proteins to those food proteins. Doesn't necessarily mean that they will have that, but there's a possibility that if you have a person that's allergic to avocados and kiwis, that they could develop a cross allergy to latex and vice versa. Thank you. Remember, there is a population group. We as healthcare providers can develop latex allergies because of overexposure. We put on latex gloves, I don't know how many times a day, on and off. So you can later develop a hypersensitivity because of overexposure. People or kids, especially kids that have chronic conditions or conditions that require a lot of surgeries in childhood, they can develop latex allergies. Patients who have spina bifida, that they are born with it, again, because of overexposure, over time, they can develop allergy to latex as well. So very good. Remember, there are different kinds, all allergies. We treat them based on the severity. There are allergic reactions that we can treat simply with an antihistamine. There are others in which, you have an anaphylactic reactions, and then you need to give epi, right? need to give, sometimes you need to give epi, antihistamine, bronchodilators. You need to do the whole shebang because the reaction is very severe. Remember, sometimes you get the epi one time and one dose is not enough. By the time the medication wears off, the half-life wears off, the body's still fighting that reaction. So the client could still develop symptoms and a second epi might need to be given, which is why it's so important that if you have those questions and when the client has a reaction and they're in the street or they're in the school and then, oh, they gave an epi, what do you do next? Okay, yeah, you can go home. No, that person needs to be transported to an emergency department. And when they get there, the determination is going to be made whether this person needs further treatment or that's it, even if the epi will take off or treat the initial threat of losing the airway, right? It will open up the airway and will kind of help the person breathe better. There's still a chance that later on, once that wears off, they will keep developing symptoms. Let's see what else here. You could have an allergic contact dermatitis. This is the rash, the itching, the vesicles. Um, like it says right here, it can happen later. It doesn't need to happen right away. It can happen 3 to 4 days after exposure to rubber or latex. Obviously, balloons, remember, balloons are made out of latex. Condoms are made out of latex. So people allergic to latex need alternatives and safe alternatives. Remember, there are condoms that are made from like natural, I guess natural skin, like animal skin, but those are not effective, at least not effective at preventing pregnancy, because also with STIs, because they have porous, skin, even if it's animal skin or us skin, has porous, right? We have little holes from which things come in and out. We absorb things, we excrete things. That's the problem with those condoms, that if they have those porous materials, if they say natural condom or a condom made out of the skin or something like that, usually that's not effective at preventing STIs, not effective at preventing pregnancy. Those are not a good form of contraception because of that porosity, okay? Very good. Let's see. So this is specifically a type 4 hypersensitivity reaction, is when it has a delay onset, when it happens later. We mentioned anaphylaxis. Remember, in anaphylaxis, then what is the person going to do? And anaphylaxis is a type 1, right? Going back to MedSearch, right? Type 1 hypersensitivity reaction. Remember, there's difference, right? It can give you initially, it can give the client GI symptoms. The client maybe get crampy, vomiting, right? Like a projectile vomiting or projectile diarrhea or a terrible stomach ache. But then they can also have a drop in the blood pressure. Obviously the swelling, the coughing, they start coughing and coughing and coughing and having difficulty breathing because the airway is closing. And obviously, this is just the different reasons why, different elements that can contain latex. Very difficult in the medical setting because most of the things we use have latex, from gloves to catheter tips, right? So if you have this, if you come in contact with one of these clients, you need to request the special equipment, and you need to obviously anticipate to order all of this special equipment before your patient gets there. You need a sign at the door. You need to let everyone that comes in contact with your patient that this patient has this latex allergy, right? Because it could be on stethoscopes, it could be on, like I say, catheters, nipples, pacifiers, condoms, diaphragms, etc., etc. Very good. Good job, guys. I don't know if there's anyone who wants to add anything to that. If no, we'll move on. Next one. Who wants to read this one? Don't be shy. Please don't be shy. And don't worry. Don't tell me, oh, my accent. We all have an accent. Nobody? Come on, guys. Don't let me hear by myself.
I will.
There you go. Thank you, Gerald. I love it. Go ahead.
Okay, the charge nurse is reviewing Event staff nurses experience or have double voice. Sorry.
Events that the staff nurse is it too small? You want me to make it a little bigger? Because I know sometimes you have to read from your phone.
No, it's I am listening my voice.
Oh, okay. Oh, you have a
It's a
background.
feedback.
Let me mute myself and see.
Okay, you hear me now? Okay. The charge nurse is reviewing events the staff nurses experience during the shift. Which events require an incident occurrence report to be completed? One, client determined brain dead was taken off life support. Client with alcohol intoxication physically assaulted a nurse. Three, serum troponin level was prescribed but never obtained. Four, staff nurse did not present for work and did not notify management. And five, visitor fell and refused care in the emergency department. Which one?
Very good.
Once.
So incident or occurrence report. Let me get my chat. So what you guys are saying. So obviously it's an incident and occurrence report is something that happened and maybe shouldn't have happened. Um, Obviously these incidents reports, these are the ones that do not go into the medical record, right? But doesn't mean that we don't document them. We still need to document this. Here, it goes all the near miss events and the sentinel events, all of those. No, Elio likes number 2. Yeah, somebody assaulted you, even though they were with alcohol intoxication or with maybe they have, I don't know, dementia, whatever it is, but it's an assault. Someone assaulted you. Again, we experience this so much that maybe we're just numb, but yeah, this, and you can also press charges if you wanted to. Number 3, there was a troponin that the doctor prescribed you a troponin for your patient and you did not obtain it. Some damage can happen here, right? Especially because the type of laboratory result they want is a troponin. This is important. Medical decisions are going to be made based on those results. We could maybe miss something if we don't do that. The harm can come to the patient. So good. And number 5, there was a visitor that fell and now they refuse care in the emergency department. Even though they refuse care, we still need to document that they fell because maybe they refuse care right now, but what if tomorrow then they woke up with a neck pain and then they want to seek care the next day? Because sometimes the pain and the things come, people are on the adrenaline and they're like, I'm fine, I'm fine, I'm fine. I don't want anything. But then they still fell, right? Should not happen. We need to record. What
Doctor,
else?
in the real life, in the event that the visitor failed and refuse, like this example, that happened in real life. If they sign a paper like a
Like the
consent,
AMA, the AMA to
yeah,
leave.
that's the
Yeah.
paper. Yes. So still, we need to do the. We
We,
need
we need to we need to do an
write
incident.
an incident report.
Yes, the incident on the fall, right? Because the
Got
person
it.
still fell, right? So we're gonna document the fall. I'm sorry. Um, Along with that, like because maybe the person refuses care, but you know, we could just assess what we see. And remember, in incident reports, we're going to document only what we see, what we witness, only factual information, right? So if you witness the fall, meaning you actually saw the person coming down, you can describe what you saw. But if you just came in there and found that person on the floor, that's what we're going to document, right? Came into the ER, found the person laying on the floor. I don't know. they were, you put the time, maybe you can describe the position that we're in, you know, uh, we offered treatment to the patient. The person
Mental
was
status.
talking, mental status, the person was talking. If the person tells you, you can put in quotation what the person say. Um, you can say what you did, what you offer. You could do a little, because we can kind of check, right? Again, doesn't mean because we can assess, um and think, okay, she looks perfect. And then remember, sometimes there's, if they hit their head, sometimes there's a hemorrhage will take time and then they will develop symptoms later. But that obviously at this present time, we don't include that, right? This could happen. No, only what happened. You cannot say they possibly hit their head unless you saw them hit their head. So only what you saw. It doesn't have to be extensive. This could be just 3 sentences of what you saw, what the person said. Patient offered treatment, patient refused. You can specify what you offer. Um, you usually will bring in a charge nurse, doctors, or whatever. And then the AMA form will be signed there because if the patient refused the care, now here's the thing, because the patient is refusing care for that fall. So it will be something different. This needs to be noted because I don't think AMA would apply because AMA applied to someone who's already your patient, meaning they came in, we're giving them treatment, and then at in some point in the treatment that we were given, the person decided, that's it. I don't want this treatment anymore. I'm leaving AMA. I don't care what you say. I'm leaving right now. That could happen. But in this case, this person was visiting, meaning this person was not under our care. We just simply, they fell. We offered them, hey, why don't you come to the ER so we can check you out officially, so we can give you a CT, so we can maybe run some images, make sure that you're okay. No, the person say no, so we just document that. Because in reality, uh, the protocol might be different in the hospital, but in reality, this person is not your patient. So we should not be treating them like our patient. We're going to obviously assess right away. If there's a bleeding, we probably can do like first aid to try and stop that bleeding, but not necessarily treat them as our patient. If you're in a hospital, you usually will call and say, hey, someone fell, we need to transport them to the emergency department, or they might have a code for that kind of thing. And the transport team will come and transport that patient, but we're not supposed to render like help right there as our patient, unless it's like a collapse and the person, falls and then they're on cardiac arrest, and then we operate under that emergency act, right? But usually, even if you start performing CPR on someone who just collapses there's other people that are going to come and take over, and that's it. All right. So yes, if it's especially important to document that we offer the help, because if the person comes back later and said, oh, I have symptoms now, maybe they want to file a lawsuit, I don't know, then it is there documented that what you saw, what you found, that the person fell, and that you offer the treatment, but the person refused it. It still doesn't mean that they cannot sue. Yes, they can sue, of course, because like I said, sometimes symptoms will not come until after. But it is important that you have documented that you did your due diligence, that you just don't ignore this person and send them off, that you did offer them to go get checked out. I don't know if that helps like clarify it a little bit. You're out.
Hit it, hit it.
All right. Very good. So, how about, hold on. How about, well, for number one, no. How about for number four? You guys don't like number four? No, just leave it like that. All right, let's go. Very good. Great job, guys. Beautiful. Perfect. So yes, any sexual assault, physical, verbal, or sexual, should be reported. Listen to what it says, verbal, because we as nurses kind of get used to patients just mistreating us. You don't have to. You can write that in your note and you can report that and you can, refuse to take care. If a patient continuously throughout your shift keeps assaulting you verbally, you can say, listen, I cannot take this anymore. I'm not going to take this patient. But obviously make sure that you document all this and ask your charge nurse to change your assignment. You don't have to take abuse, right? But like I said, sometimes we as nurses get a little numb to it. Also, keep in mind that if you do have a patient who's confused, if you do have a patient who has dementia, who really they're not doing this purposely, they have a condition, a medical condition that's making them react like this, we tend to be more understanding. But if your patient is just being rude because they want to be rude, that can be reported. Falls all need to be reported, even if there was no injury. That's what it says, with or without injury. The staff and visitor falls regardless of acceptance or refusal of treatment. Important, right? Visitors and staff too. If you fall, or if one of your coworkers fall or fell, needs to be documented. So we talk about number one, inadequate or delayed diagnosis and monitoring. Absolutely. If there's something that needs to get done and you delay something that is life-threatening or could be life-threatening for the client and you delay that or you don't prioritize that, you could be liable for that. Delay, omission, or incorrect performance or administration of prescribed therapies or medications. Absolutely. Usually you have about an hour. Remember, when prescribing medication, we have 30 minutes before, 30 minutes after the administration of a medication, like that grace period to give it. Sometimes it will be very busy. So if you are very busy, you can always ask for help, or again, try to prioritize, right? Specify the reason why, you couldn't give your medication on time. Hospital equipment failure, yes, absolutely, because, hospital equipment fails all the time, and you're gonna have to report that, because obviously nobody's gonna know that it's broken if, everybody knows in the unit that it's broken, but we never contacted the person that can actually fix it. Very good. For number 4, right? This is a management issue, right? Meaning this doesn't need an incident report. Obviously, maybe the manager might write her off, might give her a warning or something like that, but it's a management thing in reality, right? The manager or the charge nurse are the ones that deal with this, not necessarily incident reports. Gerald, can you keep reading?
Yes. The
Go
home
ahead.
health nurse is caring for a client who is receiving supplemental oxygen. The nurse notes multiple stacks of newspaper that obstruct the walkways in the client's home. Which of the following actions should the priority for the nurse to take? 1, request a referral for mental health services. 2, access the client's stressors and coping skills. 3, teach the client about the safe use of oxygen. 4, remove the newspapers from the client's home.
All right. So what do we do as a priority? The Nclex have asked about this recently, but it was someone who was using oxygen, if I'm not mistaken, and there was like an open flame. I don't remember if it was in the kitchen or a chimney, and then like a bunch of options of what you need to do or what you can and cannot do while using oxygen at home. So safety. Okay, let's see. Noelia likes number 2, Laura likes number 2, but Junie likes number 3. Teach them about the safe use of oxygen. Now, let's look back at the question. This is at home. This person is using oxygen at home. And we can see it seems like they have a hoarding problem, right? Based on what we are looking at, right? There's a bunch of newspapers. They covered the walkway, meaning that if God forbid something gets spark and flames and newspaper are gonna just, that's gonna blow up, right? And the client might not be able to escape because again, there is a bunch of newspaper obstructing the walkway. You're gonna have to climb over that. So a referral for mental health services, yes, they're gonna need. Is that the first thing we need to do? Probably no, because we need to make sure that this person is safe. That in the event of a fire, they know what to do, especially because they're using oxygen. What are the things that can ignite oxygen? What are the things that can make, remember, one thing with fire is a fire needs oxygen. The more oxygen, the bigger the fire. And if there's other materials there that would, kind of feed the fire, what can happen? All right. So you guys assessing what are the stressors, what are the coping skills, because I'm guessing you guys are thinking of that because of the
How
word
about teaching?
assess. Thank you, Gerald. I don't know if that's because remember, I told you guys earlier, there might be times in which assessment might not be number one. Now here it says assessing the stressors and the coping skills. This is when it comes also to mental health, right? And when it comes to mental health, stressors is what's causing you stress in your life, and what are you doing to deal with that? Basically, that's what it's saying. That's what number 2 is. Tell me what's stressing you out and how do you deal with that? Although it's important when it comes to safety, would that help us save this patient in the event of a possible fire? I don't know. Even though the word assess is there, this is just giving him a strategy. So maybe, okay, we need to clean this house. It's not safe for you to live here, especially because, clearly there's a mental health issue. But if you're using oxygen in your home and you have all these newspapers, there is a safety risk here. If this catches fire, you can die. I think that's the priority, other than, okay, tell me what's causing you to accumulate all this. Because obviously, yes, there's something that is causing them to accumulate all these things and to not clean their house. And they definitely need counseling. But I don't know that that in itself is going to address the main issue, that is the possibility of this person causing a fire. So teach the client about how to use that safety. Let's teach him and let's say, hey, this is the way that when you use your oxygen, these are the precautions you need to take. This is what you need to do to make sure that you're safe. Or number 4 is, okay, we're going to remove all the newspapers from the client homes, which eventually could be, but remember, if you're dealing with a person who is a hoarder, they value possessions, right? There's a lot of emotional value attached to it. And just ripping them off is not something that they're probably going to be too open to. This needs to be a process. There needs to be therapy. They need to go through the things. It's exhausting and it's long, and they need to make the decision of, okay, which ones they're going to keep, which ones they're going to let go. It's a whole process that, although, yes, eventually that would be a goal, doesn't necessarily mean is what we need to do right away, right? The just the part that is saying remove them is like we're just taking them off, and I don't know, this needs to come from the client. That's what I'm thinking. I'm inclined, I'm between 2 and 3 as well, but I think well, yeah, not so much number 2. You guys still like number 2? Gonna stay with assess?
I like number 3 more, but it's like in between both. But I
Okay.
go more because you can assess the stressors and coping skills, but doesn't solve the problem. The patient needs to know
Safety.
Uh,
Yeah.
Safety is more knowledge.
Mm-hmm.
I don't know.
Mm-hmm. And
Maybe
eventually the goal would be to, yes, remove all those newspaper because that's definitely a fire hazard, a huge fire hazard. So between 3 and 4. What do you guys think? If this was my exam, I probably would go with number 3, I think. I would go with number 3.
I don't think you can remove the newspapers from the
Yeah,
client's home
right? It's just like, okay,
without.
I'm
Yeah,
taking all
that's
these newspapers out.
yes,
That's
that's
how I read
aggressive.
that. I don't know.
Yeah.
Because it might be through therapy and all of that, but again, we're making that part up. That's not what the
Yes.
what the option's saying. The option just saying that we're
We
gonna
need to
remove
know
them.
first why we're removing it and
And
under
it's a
his
process,
authorization,
right? It's a whole
the
process.
process. So first, then that is teaching. In my opinion, that would
I
be.
think so. I think so too.
But anyway, let's try
Let's see. So we're
it.
2 by 2 and 2, right? There's 2 people who like this. Who's gonna break the tie? Because Junie is between the both. Junior, you break the tie. Okay, this is it. It's go time. We need to answer something. Which one would you go for? Or someone else? It doesn't have to be Junie. Anyone else? Who's gonna break the tie? Send me in the chat. It doesn't matter. Let us know. At this point, I don't know. Junie's confused. So someone else. Someone else. Sheresare. Lisette. Mi vida. Hi. Melissa. If this was your exam. Lisette, you tell me what did you go for?
Guys, we're practicing.
Come on, guys, don't be shy. I know. I gotta go soon because we have new students soon.
Yeah.
The new Bright Star meeting. Connie likes number 3. All right. Connie broke the tie. Let's go for it. Yes. All right. So good. Good, good, good. So I like that we had the question just because, again, when it comes to the strategies, although assessing is the number one thing we do on the AdPi, sometimes assessing is not the right answer. And if we think about this, when they're giving us all this information, that's an assessment, right? The person is a home health nurse. You go to the house, they're telling you that your client is using oxygen. That's an assessment. You're looking at it, you are assessing that there are multiple stacks of newspapers, that those newspapers are obstructing the walkway, that you cannot walk safely in this client's home, you cannot find your exit. So that's an assessment. Um, the next implementation will be removing the newspapers. But again, when we're talking about the therapeutic part of this, we cannot just remove, right? This is what we're just talking about. We cannot just go and remove, especially because there's a big emotional part of that. So the correct thing would be safety, because again, out of all the options, although this might not be right, this might not be the correct, this might not need the correct, like in the correct, or the first thing that you would do with this set of options that you have in front of you, that was probably the best. Because again, here, the question is safety. And out of all these options, number 3 is the only one that is going to teach this client safety. Okay. Um, this can ignite a fire. Yes, it's okay, no worries. This can create a fire, right? You can go ahead and remember that friction, any sort of friction, any sort of static, anything that can cause a spark, like wool. That's why we tell these clients that they need to wear clothing that is cotton and not wool, because if there's friction there, that friction creates static. Static can create a spark, and a spark will go and throw all the newspaper on fire, right? So very good. And this is why we don't just remove their possessions, because again, this client is going to have a hard time discarding their possessions, right? For them, you walk in there, you and I, who do not have a hoarding disorder. For us, this is just trash. But for them, every single piece of paper probably has an emotional component. They might be able to tell you, well, it's because this newspaper, and they might give like an emotional part to what they collect. Like we said, yes, this is hazardous when it comes to oxygen use. We are going to teaching about safety use of oxygen, why that there is an increased risk of fire due to that accumulation of newspapers and boxes. What else do we need to do? Yes, this person need to put a no smoking sign at the home and safe storage of the oxygen tanks. You can put it at the door, you can put it in your front yard, just a sign that let other people know that and that's why when you go to hospitals or medical facilities or long-term care facilities, you're going to find those signs all over the place, right? Oxygen in use, oxygen in use. Why? Because, if someone smokes and next to that little spark, the little flame can spark a big fire. That's why we teach about the clothing, and that was the whole famous clothing. Wool clothing is not good because the wool, like I explained before, creates ecstatic. Very good. And number 4, yes, we need to ask the client about the necessity of cleaning the home and removing that. But like I said, this is going to only create more anxiety on the client. This is a process. Very good. Next question.
Which measure will help prevent falls in the elderly client of a long-term care facility? Select all that apply. Yeah, exercise programs, good room lighting, handrail and in stairwell, smooth sole shoes, staff hourly round.
Very good. What do you guys think? Let me go see my phone.
2, 3, 4. Sure.
2, 3, 4. I like that too. Oh, wait, 4. Smooth sole shoes. What does that mean?
Well, when they're not smooth, they grab the ground and you can, that's what
So
I
the
remember.
sole, yeah, the sole is like the bottom part of the shoe, right?
Yes, yes.
If it's too
If you put rubber
smooth,
sole in the client, they sometimes get stick to the
sticks
floor.
to the floor, and it can,
Yes,
okay,
that's what I remember. Maybe I'm wrong.
okay,
That's what I'm.
okay. Junie doesn't like number 4 because maybe what Junie is probably thinking that they can slip if there's just there needs to be grippings on it or an anti-slip. You know how the socks that we put on our patients, they're not
Yes,
necessarily
yeah.
smooth and soft. They have like those little creases that are rubber.
Well, actually, yeah, makes sense a lot.
It makes sense. Now, again, another strategy, because it might be that Gerald is right, and he's saying that yes, it could happen that if the robber, especially people who are elderly with Parkinson's, that they have that little shuffling gait, and if they go like that, then their shoes can kind of get stuck and actually trip them when they stuck to the floor. But that's an exception, right? It is safer to have good gripping shoes rather than the smooth. Now, as a strategy, if we're not sure, what we do is we leave it alone. Noelio likes number 1.
Yeah, when
Which
it says smooth
exercise is not
sole,
going to be
it's
a good
like
option.
flat, 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 right?
Yeah, it's exactly smooth. What they mean is very soft. It's smooth. Something smooth
No
is something
gripping, nothing.
soft at the bottom. Exactly, soft at the bottom. And Junie also likes, Melissa likes 2 and 3. Very good. Tani likes 2 and 3. What do you guys think of number 5? Noelle also likes number 5. We have the staff doing hourly rounds, meaning that every hour we're going to pass by and prevent and see how they're doing and see, you know, make sure that a client is not trying to get out of bed and fall. That sounds like a good option, no? Hourly rounds.
You muted.
You cannot hear me? I'm not muted.
Now I hear you. Yes.
Oh, okay. Yeah, yeah. Okay, very good. So you guys like number 5 as well. Very good. Great job. Fabulous. Good job, guys. Yeah. Very good. So again, here, staff rounds require intervals decrease, false and cold light use. Yes, absolutely. If they can see you, because many times, me personally, just by rounding, just by picking in, even though I'm in a different setting, where I am, I'm in ICU, so it's very easy that usually you have your two patients very close to each other, and usually you're just sitting there documenting, and you have like an eye on your patients at all time. But if you're in a different unit and you have 4, 5, 6 patients, you're going to be rounding right all over, and you're going to be all over, and you're probably going to pick a place to sit and document. So you're not always going to be looking at a patient. But I've many times, if I'm helping someone else, if I'm doing something else, and just by coming in, I have many times have found patients literally just trying to slip out of the bed and just trying to get off, and I have prevented a fall because I went in there and I'm running about, I'm taking a pic, and I find them literally with one foot out the bed. So definitely hourly rounds can help, you can just take a pic, go around, just walk and look, make sure that everyone is safe in their seats or in the bed, that nobody's lighting off and about to be on the floor. Very good. So staff checks on the piece. Yeah. This is so funny because we actually document about this, about the piece. You are supposed to do a round, an hourly round in which you are checking for potty. You are checking if your client needs to go to the potty and make sure that you help them or you provide them with the urine or what they need. Position, in which position the client is, right? Again, make sure that they're not sitting, changing positions as well, because remember, patients are not supposed to be like that. We're supposed to be turning our patients every hour, every 2 hours, so to prevent pressure injuries. Pain, yes. Are you in pain? Are you okay? Do you need pain medication? Placement or proximity of
Yeah.
personal. In our case, it's possessions. It says P for possessions. And the possessions is yes. And you'd be so surprised sometimes, like elderly clients are like, where's my phone? Where's my bag? I want my bag here next to me. And that just gives them, I don't know, that gives them a sense of security. And we're supposed to run and document that too.
Master's eyes fatten the horse.
How?
Master's eye fatten the horse.
Yes.
El ojo de la mujer de caballo.
Exacto. Exacto. Um, what else? Yeah. If they need water, if they want tissues, they bed hide many times. Again, you're not the only person that comes into the room. Maybe a doctor came in to evaluate something or to do a bedside procedure, to put an IV or something. And then, they come in, they leave they adjust the bed because they were doing something, and obviously you need to protect your bag. But then they leave, and very few will leave the bed the way you find it. So again, on those hourly rounds, you go and your patient's bed is all the way up here, and they're with one leg out, and they're confused. You need to run because you need to lower that bed and put it back again in the lowest position to prevent that. And again, usually most of my patients I try to keep them as low as possible, even if they're sedated, because you never know, and because everyone has a risk of falling. Even patients who are, young and alert and oriented, you trip on something, you can fall. So it is obviously, if your bed is in the lowest position, the damage could be a lot less than if the bed is all the way up. Very good. Next.
A client's receiving IV potassium. The IV pump display an occlusion alarm. The tubing is free of occlusion, and the IV flushes easily without symptoms of infiltration. Which action should the nurse take next? Discard potassium and document administration of a partial dose. Exchange the IV pump with a different one. Insert a new IV catheter in a different location. Remove the pump and administer medication by gravity drip.
Very good. I like this question. Very, because this is very real life. The pump keeps saying occlusion, 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 and you already look at that. They already did the assessment, right? Look at it. You did, going back to the ADPI. Right here, they're telling you they're running potassium, very important potassium. The alarm on the pump keeps saying something, but they're already telling you what she did, right? She checked the tube. Nothing is occluding the tube. Everything's open. The tube is fine. There's no kinks. And also with the IV, you went in and checked the IV. Is the IV? No, the IV is flushing. There's no infiltration. It flushes easily. It's not the IV. It's not the tubing. What do we do? And again, think of safety. And think of critical, I guess, common sense, right? No, Elliot likes number 2. Let's just change the pump. The pump must be broken. And that can happen. Equipment fails all day long. Because, we're discarded potassium. Obviously, no, we're not going to document a partial dose because a pump is giving us an error. We're not going to discard the potassium. The reason why we're replacing potassium is because this client's potassium is low. Remember that potassium is one of those electrolytes that can send a person into life-threatening heart dysrhythmias. So clearly, no. Insert a new IV catheter in a different location. Why? They're telling us right here that the IV flushed, that there's no infiltration, that the IV is working fine. So we don't need to put another IV. They're telling you there that is working. Remove the pump and administer medication by gravity drip. Absolutely not. Remember, potassium is a high alert medication. We can kill someone if we push potassium. So we're not going to give gravity drip. This medication absolutely needs to go through a pump. No. Very good. Great job, guys. And again, like I said, many times occlusions, like I said, happen because the client is, the IV is in a movable joint and the client just bend it like this, or the client sleeping like this, very easy to fix. All right. Great job. Yes. All right, guys, we're doing I'll meet you there. We're gonna do the last question and then I gotta go because we have our meeting with Bright Stars. But tomorrow I'm hoping we're gonna start at 10:30 so we can have a good session tomorrow. Good, till 10:30, from 10:30 maybe to 1. So bring snacks.
Extended version.
Yes, bring snacks. Go ahead, Gerald.
Okay, 2 years old who swallow an overdose of adult cough syrup. It's being discharged from the emergency department. The parent says to the nurse, "From now on, I'm going to store all medication in my top dresser drawer." Which is the best response by the nurse? Can you lock your dresser drawer? 2, make sure all your medicine have child-proof caps. 3, that sounds like a safe plan. 4, you need to keep an eye on your child at all times.
All right. So it's telling us right here, this 2-year-old swallowed an overdose of adult cough syrup. They're being discharged from the emergency department. Now the mom is saying, okay, from now on, all my medications are going to be on my top dresser, which in her mind sounds like a good idea, but 2-year-olds climb. They love to climb.
They
right?
figure it out.
They will figure out a way to climb up there and get the things. Now, you guys like number 2? I see number 2. Make sure all your medications have child-proof caps. I wonder how.
The lock.
The what? The lock?
Can you
Like what
lock
okay,
the
why you
dresser?
think the lock?
I mean, it should be on the top dresser drawer, but if it's not locked,
they can open it. I like that.
They will go for it.
Because look at number 2. They already overdosed on a cough syrup, which usually most coughs are childproof, and they still manage to drink that syrup. which means that they managed to know. Listen, my kids know better than me how to open up those things. Oh, they very easily figured out that they have to push down and then twist.
Push and yeah, push and turn.
And this, I like that too. That is true. But they're already telling me that this kid already opened a bottle of cough syrup. That very likely, because most bottles nowadays are childproof. Most bottles. So they already know how to open that. That's why I do like is not only that, but lock in a way that this kid cannot access it because that drawer is locked. Obviously, number 4 is we cannot have eyes on our kids at all times. That's unrealistic. It's definitely not a safe plan because not only that, the kid trying to climb over there, they can also hurt themselves when they have something that they want is too high up. In their head, they don't see, oh no, I'm gonna fall. In their head, they see, oh, a challenge. Now I have to figure out how I need to get up there and start stacking things to get up there to get what they want. Not only they can grab the thing and the medication and get another intoxication, but they can fall from all the way up there. All right, very good. So I like number 1 too. Junie likes 3 or 4. Junie, no, I don't think it's a safe plan. I think it I think it's safe if the drawer can be locked. Because kids will trust me, they figured out a way, they know they figured out how to open they just do. And in this case, this kid already opened it. He already opened it up and drank it. Very good. Great job, Tani. So again, yes, children are naturally curious and attracted to medicine. One of the reasons why we don't tell kids that medicine is candy, because then you come home with a whole bottle and they're like, look at all this candy. And then they're gonna open it and eat all that candy because it's candy, right? Um, Vitamins, kids can get intoxicated. Now remember, vitamins are now very attractive. They come as gummies, and so a kid can sit down and chug down. This is a personal story. My husband did this with his little sister. He This was in the 80s. It was the 80s. Um, his sister woke up. He accompanied her to pee because she was afraid to walk in the middle of the night. And then they passed by the kitchen. And then he was trying to be a good brother. And he's like, let me give you a treat. And then he opened up the Flintstone gummies and he fed her the whole bottle. Obviously, they have to go to the hospital. They have to pump her stomach. They almost, they interrogated the mom. Where are you? Obviously, because why did they have access to this medicine, right? A whole issue because yeah, he thought it was just, they thought it was just candy, and he felt bad that she was scared, and he fed her the whole bottle of gummy vitamins. So kids do that, guys. Kids do that. So again, yes, the kids, like we said, kids get into everything, I'm sorry, and very good that everything needs to be locked, right? Because again, just even if it seems out of reach, a child will figure out a way to find it out of sight in a drawer with a childproof lock and put them away after use. Very good. Obviously, what do we do in this case? One of the very first things this person does, besides calling 911 comes first, or transporting the person, baby or toddler, to the ER, is calling poison control, right? What do they drink and how much do they drink and what can they do? And poison control would be like the best to tell you and to kind of walk you through signs and symptoms. All right, guys, today was a little short. I apologize, but we do have this meeting that is very important and very exciting. I keep studying, keep working with you. You work tomorrow, like I say, come prepared because we're going to work a little longer. And please come back and let's discuss. Thank you so much, Jura. See you tomorrow. Have a great night. Lizzie, love you. Bye, guys. Thank you for coming.